Hello everybody, today we're going to talk. So, spinal cord injury, it affects most commonly the cervical spine more than the other uh, thoracic and lumbar spine uh, with an incidence of 50% in relation to the other spinal segments. And the most common level affected in cervical spinal injury is C5 vertebral body or the C5 vertebrae. Now, 35% of spinal injury occur at the thoracic level and 11% occurs at the lumbar level. And when combining the thoracic and the lumbar spine, the most common segments that are fractured in the thoracolumbar spines are the thoracolumbar junction. Spinal cord injury commonly results from a sudden traumatic impact on the spine that fractures or dislocates the vertebrae. For example, patients who have a history of road traffic accident, falling down from a height, uh, uh, and etc. Now, the initial mechanical forces delivered to the spinal cord at the time of the injury will cause what is called primary spinal cord injury. And unfortunately, we as doctors, we cannot alter these or prevent or to treat primary injuries. The role primarily is to prevent these primary injuries. So in primary injury, what happens? Primary injury might result in displaced bone fragments or disc materials that might compress the spinal cord or the nerve roots, or there might be a ligamentous injury, a bruise or a tear that might affect the ligaments. So this is what we mean by primary injury. Generally speaking, spinal cord injury can be classified as also as a complete or incomplete spinal cord injury. In complete spinal cord injury, there's a complete loss of all neurological functions below the level of injury, including the motor and the sensory. So a patient with complete spinal cord injury, he will have a zero power of all the muscles that are innervated from the nerve root by the nerve roots below the level of the injury. He will have no sensation at all below the level of the injury. Now, patients with incomplete spinal cord injury, they might have residual motor function or residual sensory function. Okay, now secondary injury. So primary injury, as we said before, is unpreventable. So it occurs at the accident location. So your role as a doctor is to prevent or treat secondary spinal cord injury. What we mean by a secondary injury? Secondary injury is a further damage to the spinal cord or to the nerve roots that is either due to instability and further compression of the fractured spinal segment or due to other causes. For example, a secondary injury includes damage to an ascending and descending pathways in the spinal cord due to continuous compression, disruption of blood vessels and cell membranes, and this would lead to either edema or infarction of the spinal cord or a vascular injury to the nerve root, spinal shock, systemic hypotension, and ionic imbalance and neurotransmitter accumulation. Now, how can we avoid these complications? The most effective clinical treatment to limit tissue damage following primary injury is the early surgical decompression within the first 24 hours after injury to the spinal cord. Now, what is the management of patients with spinal cord injury who present to you in the hospital? Any of the following patients, they should be treated as having spinal cord injury until proven otherwise. So, All victims with history of significant trauma or a dangerous mechanism of injury, they all should be considered to have spinal cord injury until proven otherwise. Any patients who are delivered to the emergency department who are unconscious, you should treat these patients also as spinal cord injury until proven otherwise. Minor trauma patients with complaints that are related to the spine. For example, patient who is fully conscious presents to the emergency department, and while taking the history, there's a neck pain or low back pain, or after you examine the spine, you find tenderness on palpation, or if the patient complains of numbness or tingling in the extremities, or he experience weakness or heaviness in his extremities. Now, there are some indirect findings that are suggestive of spinal cord injury. For example, abdominal breathing in patients with serious cervical spinal injury. And for example, if you find that the patient is having priapism, these two findings should alert you that the patient might have spinal cord injury. Okay, so what are the key steps in the management of patients with suspected spinal cord injury? The mainstay of the management and for the prevention of secondary spinal cord injury is immobilization. Whenever you receive a patient in the emergency department and you suspect that the patient is having spinal injury, always just put a hard neck collar, maintain a backboard and head strip to facilitate the transfer of the patient from his bed to the table. Always, if you want to drill the patient, which is also a very important part of your examination of the spine, always log roll the patient when turning him from to one of his sides. And by that, we mean that you move the head, the neck, the chest, and the whole trunk as one piece. Okay? Now, after immobilization, once you've done with all of your investigations, including X-rays, CTs, or MRIs, you can remove the patient from the backboard as soon as possible, because this will decrease the risk of having ulcers and compression neuropathies. Now, always make sure, also, the second thing, make sure that the patient is having a normal blood pressure. And whenever you see a patient who is hypotensive, always consider that this might be not only related to hemorrhage, but also consider spinal shock. Try your best to maintain systolic blood pressure more than 90 millimeter mercury by giving the patient IV fluids, or sorry, not IV fluids, medications that increase the blood pressure, which are called vasopressors. Okay. Also, make sure that the patient receives good oxygenation. If you are professional enough and you exclude that the patient is having a cervical spinal injury, or you are experienced enough to deal with patients with cervical spinal injury, try to put an NG tube safely, okay, but also bear in your mind that is contraindicated in patients with suspected basal skull fracture. Insert a Foley catheter, and don't ever forget a DVT prophylaxis if there is no contraindication for that. Okay, after doing that, you stratify your patient using the Asia impairment scale. We will discuss this later. Always make sure to have focused history in patients with trauma. Just organize your thoughts, have key questions to center mainly on the mechanism of injury, if there's a history of loss of consciousness, if there is a feeling of heaviness or weakness in the extremities following the trauma, if there is a history of tingling or radicular pain, and also don't ever forget to inspect and palpate the spine safely. Okay, look for any tenderness, any steppage, or any widening of the interspinal space. Now, what is the ASIA score, or the American Spinal Injury Association scoring system? It's a scoring system uh, to have a common language between doctors when dealing with patients with spinal cord injury. Now, the ASIA score is the score for the assessment of the severity of the spinal cord injury. The grades of, or yes, the grades of the ASIA score is starting from A to C to E, sorry. So A, B, C, D, and E. So A is the ASIA score of the patient when he's having a complete spinal cord injury. So there's no sensory and no motor function at all below the level of the injury. Now, the patient is scored as B if there is a complete loss of motor. So the patient will have a zero muscle power of all the muscles below the level of the injury, but he's having some residual sensory function below the level of the injury. So if the patient is having that, so he's scored as B. Now let's jump into E. Okay, the E scoring of a patient with spinal cord injury are patients with normal neurological examination. So patient with spinal injury, fracture or whatever, and on examination he's having normal sensory exam, normal reflexes, and normal motor examination. So these are patients who will have a score of A. Now let's go back to C and D. In C and D, if the motor function is partially spared, so the patient is having some residual motor function below the level of the injury. So the ASIA score can be either C or D. Okay. Now, the patient will have a score of D when the majority of the muscle groups below the level of the injury have a motor power of 3, 4, or 5. This means that patients where the majority of the muscles below the level of the injury exhibit strength level of 0 or 1 and 2, the patient is considered to have a score of C. Okay, this might take a little bit time to understand, but if you go over the recording, you will find that it's not that difficult. Okay, again, this is the ASIA scoring system, complete. A, E is normal, B, C, and D are incomplete spinal cord injury patients. B, patients have a complete motor deficit below the level of the injury. C and D just measure the power of the muscles below the level of the injury. If the majority of the muscles, motor power of these muscles score 3, 4, or 5, the patient will have a score of D. If most of the muscles or the majority of the muscles below the level of the injury, they have a motor power of 0 or 1 or 2, so the patient will be scored as C. Okay, now this is the standard neurological classification of spinal cord injury, and let's agree that this is the standard motor and sensory assessment regarding the nerve roots that innervate the joint movements and the dermatomes of the body. So if we look here, so the key muscles the 10 key muscles, 5 in the upper limb and 5 in the lower limb. And here are the motor power grading, okay, which you should know by now. So a C5 is responsible for elbow flexion, C6 is for wrist extension, C7 is for elbow extension, C8 for fingers flexion, and T1 for finger abduction. Now let's go to the lower extremity. So the L2 is for hip flexion, L3 hip extension, L4 ankle dorsiflexion, L5 big toe extension, and S1 ankle plantar flexion. Okay, so if we want to decide if the patient, for example, is either scored C or D, we measure the power of these 5 muscles and these 5 muscles. If the patient is having, for example, cervical spinal injury, and out of these 10 muscles, if more than 50% of the muscles score a motor power of 3, 4, and 5, so the patient is considered to have a HU score of D. Now, these are the standard dermatomal distribution of the upper extremity, as we discussed previously on the clinical teaching sessions in the hospital. Okay, good. Now, as we said before, clinical evaluation, always take a proper history, a focused history. Okay. The most common symptom in patients with spinal injury is axial non-radiating pain, either in the neck, the thoracic spinal area, or the lumbar area. This is most likely a stabbing or aching in nature. Okay. Also, sometimes patients with neurological injury will complain of weakness. So in this situation, feeling of weakness or complaining of weakness is a symptom rather than a sign. If you detect weakness on examination, so this is a sign rather than a symptom. Also, they might complain of paresthesia or anesthesia below the level of the injury, and they might also have, they might tell you that since the trauma, if they are conscious, I haven't passed urine in the last 3, 4, 5 hours, and he can't feel that he needs to go to the toilet. On physical examination, as we said before, always look over the patient carefully to inspect the sign, look for abrasions, tenderness, increase in the interspinous space, and palpate if there is any gap between the spinous processes. Neurological injuries before the L1, they will produce, above the L1, it will produce an upper motor neuron injury. As you know, that the spinal cord ends at the level of the L1, L2 intervertebral disc. Now, below that, injury to the spine will lead to symptoms and signs of a lower motor neuron injury, because this will affect the coda equina nerve roots. Now, a very important topic to know is the incomplete spinal cord injuries. And these injuries, as we said before, these syndromes, they occur when the patients have a spinal injury above the level of L1. Now, let's mention the important motor and sensory tracts in the spinal cord. So here is the lateral corticospinal tract, which is located almost laterally, okay, which is a motor tract, and the ventral corticospinal tract, which is also motor, is located here anteriorly. Now, the sensory tracts are the dorsal columns here. They are responsible for deep touch, proprioception, and vibration. Now, the lateral spinothalamic tract, which is responsible for pain and temperature, and as you may know that the lateral spinothalamic tract is the only tract in the spine that crosses to the other side. The rest of the tracts, they cross at the level of the medulla oblongata. And the ventral spinothalamic tract, which is responsible for the light touch. Okay, so here, the dorsal column, lateral spinothalamic tract, again, the ventral, the lateral corticospinal tract is there, and the ventral corticospinal tract. And these are the other spinal tracts. Now, when talking about incomplete spinal cord syndromes, either we talk about a central cord syndrome. Here, the trauma is mainly at the center of the spinal cord. Okay, and this scenario occurs most commonly in patients who have a cervical spinal stenosis and they sustain a slightly hyperextension injury. This will lead to central cord syndrome. And as you see here, the affected area is the center of the cord. And the the special feature of central cord syndrome is that the patients will have upper extremity weakness that is more severe than the lower extremity weakness. And why is that? If we look here at the lateral corticospinal tract here, the cervical segments are present here, then the thoracic or lateral, then the lumbar, and then the lumbar and the sacral nerves. So as we go laterally or away from the midline or the middle of the spinal cord, we go far from the corticospinal tract responsible for innervation of the lower extremities. So when you have a central cord syndrome, the pathognomonic feature of the central cord syndrome is that in the cervical spine, of course, is that the patients have a motor weakness in the upper extremity more severe than the lower extremity because the cervical segments here are more or nearer to the middle of the spinal cord, which has been injured. Now, let's go to C, which is Brown-Séquard syndrome, which is a hemicord section. Here, the most common mechanism of injury is a stab wound from the back, okay, in the area of the thoracic spine. Here, all the tracts are affected, so the patient will have impairment in all of the sensory and all the motor functions of all the tracts mentioned before, which are ipsilateral to the lesion, and the only modality of sensory impairment is the pain and temperature, which will be contralateral to the lesion or to the injury. And why is that? This is because that the lateral spinal tract, as we said before, it crosses the spinal cord 2 or 3 levels above or below. Okay, so the patient will have an ipsilateral motor weakness and ipsilateral dysfunction of the dorsal column and the other sensory tracts, and a contralateral loss of pain and temperature. Now, talking about the anterior cord syndrome here. So these patients, most likely they will present with bilateral dysfunction of all the tracts, the motor and the sensory, except for the dorsal column. So the patients would have bilateral weakness, bilateral loss of crude touch and itching, and pain and temperature, and the only modality that is spared is the dorsal column, the vibration, fine touch, and proprioception. So, and the posterior cord syndrome is the opposite of the anterior cord syndrome. Here, patients mainly will have dysfunction of the dorsal column, the vibration, the joint position, and the fine touch, and the rest of the sensory and motor tracts are preserved. So this is a summary of what have we discussed. So the central cord syndrome, most likely in cervical spine, cervical lesion with upper greater than lower extremity paresis. As we said, anterior cord syndrome, most likely it is due to vascular insult. Okay, posterior cord syndrome, it's the rarest among the 4. Okay, and Brown-Séquard syndrome, as we said, there is an interruption of the lateral half of the cord with loss of ipsilateral motor and touch, and with loss of contralateral pain. So, and these are common causes of what we have discussed of the spinal cord injuries, talking about complete cord transection. This will lead to complete spinal cord injury. Causes are trauma, infarction, transverse myelitis, spinal intramedullary abscess or intramedullary tumor. These are the findings of complete spinal cord injury. Cord hemisection, Brown-Séquard syndrome, okay, central cord syndrome, and anterior cord syndrome. Okay, this is almost repetition of what we have discussed earlier. Now, radiological evaluation. Now, going back to patients with history of spinal injury. So, the aim of the radiological evaluation is to check for the alignment of the spine and to look for any rotation or translation, to assess if there is any kyphosis, if there is any loss of vertebral height, and if there is any widening of the interpedicular space or interspinous distance in AP X-rays. Now, in CT scan, it is the best to assess the bone, as you know. And MRI, it provides information on spinal cord or nerve root injury. Okay, and if there is any spinal cord edema or hemorrhage or any epidural spinal hematoma. Okay, now this is an example of what is called a burst fracture. So on your left-hand side, as we see here, so this is lumbar spine, this is the sacrum, this is the L5, this is L4, L3, L2, L1, and T12. So this is L3 burst fracture. This is a lateral X-ray. This is a bone window of the lumbar spine, showing the, as you see, a more detailed image of the fracture itself. Here you can see that there is some bony fragment protruding posteriorly, compressing the caudate equine nerve roots. This is an axial cut, most likely over here, because we can see the pedicles. Pedicles are here and there. These are the facet joints. These are the transverse processes, and here is the where the lamina is, and this is the spinous process. As we can see here, this is the vertebral body. Should be like that here and there, and here is where the bony fragments that are seen here. It is clearly compressing the caudate equine roots. Okay, another example. This is not the same patient, so this is a sagittal T2 weighted image MRI. This is the sacrum S1, L5, L4, L3, L2, L1, and T12. As you can see, this gives us a way much better image for the spinal cord itself. This is also a burst fracture of the T12 vertebrae. There is also posterior displacement of bony fragment, almost touching the spinal cord. And also this gives, the MRI is also great for if there is any, as we said before, spinal cord edema or contusion or any ligamentous injury, either interspinous or other ligamentous injury. Okay, and also the facet joint capsule. Now, management. So as we said before, resuscitation is very important. Immobilization. Okay. Now, the idea for surgical intervention. Surgery is done for unstable fractures. Now, what is the definition of a stable fracture or unstable fracture? How to decide that this fracture is stable? So the management will be, for example, orthosis, okay, or this fracture is unstable and needs surgery. So stability of a segment is that that segment, when bearing normal physiological loads, will not lead either to deformity in the spinal curvature, motor weakness due to nerve root compression, or any myelopathy due to spinal cord compression. So in the absence of these things, the fracture is considered stable. And there are few classifications for mainly for the thoracolumbar fractures to score the fractures as stable or unstable fractures. For example, there is a classification. We will not go through it. There is the thoracolumbar injury classification and severity score by Vaccaro, and there is the AO classification. So what we need you to know is that surgery is done for patients with severe or progressive motor weakness and for patients with unstable fracture. Okay. Now, steroids. Steroids has been used for years, but nowadays the usage of steroids in patients with spinal injury is not proven as a standard of care anymore. Now, this is one of the most common orthosis you might see. Might be not the best picture to show, but I want to show you the idea behind orthosis. So this is a thoracic or thoracolumbar support. Okay, the idea is like treating any fracture. For example, the extremity is immobilization for 6 to 8 weeks of the fractured area to allow the body to heal by itself.